Okay, I think we can start. So I welcome you all to the World Patients Alliance World Patient Safety Day webinar on patient engagement in medication safety. My name is Hussein Jaffrey, and I'm the Executive Director of the World Patients Alliance. I've also remained the Vice Chair of the WHO's Patients Advisory Group, and I've also been, part of several other international organizations on their boards, and mainly working on patient advocacy and patient rights. So just a word about World Patients Alliance. We are the largest patient organization in the world that's working across all disease areas and in all regions of the world. We currently have over 375 members in 114 countries of the world. So coming back to the World Patient Safety Day webinar, so it is commemorated on 17th of September every year. And this is the fourth, I believe the fourth World Patient Safety Day. The theme of this year's day is medication safety, and the slogan is medication without harm. So last year in 2021, the World Patient Alliance, we ran the world's largest campaign on World Patient Safety Day. We organized more than 800 events all over the world through our members in different countries of the world. And this year as well, we have again running a big campaign. We have given grants to our members to organize the World Patient Safety Day event. So I'm sure this year again we will run a very big campaign. And this webinar is part of that campaign that we are running this year. Taking this opportunity, I would like to thank our speakers for this webinar, and that includes Alpana Meyer, Michael Cohen, Philip Rutledge, and Helen Najajija. So, and my special thanks to Helen Haskell for leading this webinar and moderating it. She is a real force behind our patient safety work at the World Patient Alliance. So before we start, I would like to let you know that I'm very pleased that we are also going to launch a video on medication safety, and the idea behind this video is to create awareness among patients, community, and also among family members and everybody. So it's a general, just less than 2 minutes video on medication safety. So can we have the video?
An introduction to medication safety, brought to you by World Patients Alliance, www.worldpatientsalliance.org. Do you take medications? Almost everybody does. But what do you know about medication safety? We all need medications sometimes, but medications are powerful agents that need to be used with care. Did you know? Medical error is one of the leading causes of death and disability in the world. About half the harm from medical error is caused by mistakes with medication. At any given time, about every 10th person in the hospital is there because of harm from medications. Medication use has increased by about 1/3 over the past decade. As the number of medications goes up, so does the risk of harm. Not all harm from medications can be avoided. That is why it is important to take only the medications you need in the amount you need and no more. What can you do to take medications safely? Know what each medication is for and how long you should take it. Know the potential side effects. Be careful of over-the-counter medications. They can have serious side effects just like other medications. Take the smallest dose you need. Keep a list of your medications. Review your medications regularly with your provider. Do you still need them all? Are they all safe to take together? Report side effects to your prescriber or to your National Center for Reporting Adverse Drug Events. To learn more, visit the World Health Organization or visit World Patients Alliance, www.
Okay, so I hope you enjoyed this video, and you can use this video. And the link is available on the World Patients Alliance website. This is available in both in English and Spanish, and we plan to bring it in other languages as well. So now I would like to request Helen Haskell to take over the webinar as the moderator. Helen is a big name in patient advocacy, in patient safety. She is the president of the Mothers Against Medical Errors and Consumers Against Advancing Patient Safety, and she's also the former chair of WHO's Patients for Patient Safety Advisory Group. And she's also a member of WPA's Patient Safety Committee. In fact, she's leading this committee as well. So I request Helen.
Thank you, Hussein. I am very happy to be here, delighted to have the opportunity to be here and talk to you a little bit about medication safety. I led the Patients and the Public working group on the WHO Global Patient Safety Challenge. And through that, I met a number of our speakers today and wanted to further the topic of patient engagement. So we're very fortunate to have some of the really global luminaries of medication safety here with us today. We're going to hear from Alpana Mayer of the Scottish Government on the topic of polypharmacy and managing medications for people with multiple medical conditions. We'll hear from Michael Cohen of the Institute of Safe Medicine Practices in the US on how to take your medications safely. Professor Phil Routledge from Wales will talk about high-risk situations and medications. And Helen Nagaje of the National Drug Authority of Uganda will talk about her intriguing research into community education on medication safety. I think this is really for everyone. If you're interested in medication safety, or if you take medications yourself, as we all do, you'll come away having learned something new. This is our agenda. This is a 90-minute webinar. We have the 4 speakers followed by a discussion and question and answer period. So please turn off your cameras and keep your microphones on mute until that time. We will save our questions and answers with the speakers until the discussion panel at the end. So please put your questions in the chat as they come to you, and we will relay them to the speakers and they'll answer them at the end. So without further ado, we will get on with our program. Our first speaker is Alpana Mayer, who is probably the world's expert on the subject of polypharmacy. She's head of prescribing and therapeutics for the Scottish Government. She developed the National Polypharmacy Clinical Guidance for Scotland with a patient app and shared decision-making tools, and has led 2 really path-breaking EU-funded multi-country programs on addressing the problems of polypharmacy. She leads the WHO work for polypharmacy and is an expert and advisor and consultant for WHO. So Alpana, take it away. Alpana, you are unmuted.
Thank you, Helen. Yeah, it just takes a minute to come off. So thank you, Helen, for the kind introduction, and thank you for the invitation to speak to you today. And hello, colleagues. It's lovely to be with you today. So as Helen said, I'm really going to talk to you today about the patient role in addressing inappropriate polypharmacy. I'm going to set out what polypharmacy and inappropriate polypharmacy is, and the key role that patients and their family and people can play in addressing this particular issue. Next slide, please. So I'm sure this data is familiar to many of you, and you will have seen this before. So globally, we have an aging population, and as people grow older, which is a good thing, we've managed to have medicines that help people live longer, survive also at the younger ages because of improved vaccinations. But as people get older, they tend to find that they develop more long-term illnesses. And non-communicable diseases has increased globally, and particularly in low and middle income countries. And with that, we find that people correspondingly take medications to manage these long-term illnesses. And what we need to then think about is the appropriateness of all these medicines when people are taking multiple medicines. So next slide, please. So if you could just sort of click the 2 slides, if you just click and click, please. So go back one, yeah. So if we think about an individual, what it's really important to do is to think about the individual yourself in front of you, or as a clinician, you should think about the person that's presented in front of you. And you as an individual should think about, what do I want from my treatment? What's important to me? And so if we think about disease-based guidance, so if you present with a long-term illness, quite often the clinician will use a guidance that will help guide the management of the medicines to be used, the tests to be done. However, if we think about these 2 individuals that I've shown you here, that the lady that's on the exercise device and the gentleman that's sitting on the sofa, their priorities might be quite different. And also how we manage and treat them might be quite different. If we aggressively manage the lady on the left, some of the medications may affect her in a different way to the gentleman on the right. And so we do need to think about using our clinical judgment as well as using the standard guidances, because they won't distinguish between these 2 people. So next slide, please. So inevitably, what happens is as people get older or they become frail, they can also develop impairment with how their kidneys work and how their liver works. And this is really the body's way of dealing with the medications that we take. And that can change and go down with age or frailty or certain disease conditions. So as people take more and more medicines, or as they get older, we need to bear that in mind. And if you look at the pictorial diagram on the left-hand side, you can see that there are many reasons why people end up on many medicines. And as that video showed earlier, which I thought was very good, that quite often people go and buy themselves medicines as well. And now we have access to internet pharmacies as well. So it's making sure that the medicines that you take are the most appropriate for you. And when you don't need to take them, you stop taking them. So next slide, please. So this shows really data of people who are taking many medications. And you can see here that actually you don't have to be that old before you're taking 7 to 8 medicines. And the important thing here is it's 7 to 8 different medicines that you may end up having to take 2 or 3 times a day. So it's a huge burden for the individual to be able to have to take those and to manage those different medicines. Next slide, please. So WHO produced a technical report, which I had the privilege of being the lead author on, and worked with many colleagues globally in order to develop the key points that are highlighted in this report. But what I really want to pull out today is discuss the role of the person, the individual, the patient that's maybe taking some of these medicines. And the 5-step model that shows 5 moments of medication safety, thinking about at which stages an individual may want to take action and an intervention that might help them think about if this medicine is still suitable for them and still helping benefit the management of their long-term illness. So taking lots of medicines in itself is not harmful. Where it becomes harmful if those medications are doing more harm than good. So rather than just thinking about the number, it's important to think about, is this medicine the right medicine for me? And this is where the term inappropriate polypharmacy comes in, rather than saying, well, I'm taking 5 medicines, so that's definitely harmful for me. You could be taking 13 and they could all be benefiting you, so it could be appropriate, whereas you could be taking 3 or 4 and some of them may be causing harm, in which case they need to be addressed. So WHO has the 5 moments of medication safety tool, which I had the privilege of working with Helen on, and you can access that on the WHO website. So next slide, please. So we've talked about what's appropriate and what's inappropriate. So never be afraid to ask the question, therefore, if you're taking more than 1 or 2 medications. So this picture here really was, again, I had the privilege of going out to Uganda and working with some women while they were waiting to have an operation. And we just simply asked these women, are you taking one or more medicines that you would like to discuss and get help with? And what was striking was that people just queued out of the door to discuss their medicines. And many of these women were making decisions about whether they had food or they went and bought their medication. And quite often when we reviewed the appropriateness of them still being on these medicines, we found that they didn't need to take them anymore. And in fact, some of them were causing more harm than good. So it's really important to ask those questions, no matter how many medicines you take. Next slide, please. So we also know, so the chart I showed you with the number of medicines that people are taking, we could see very clearly that many people take more than 4 medicines. But what we know is that when you take 4 or more medicines, 50 to 80% of people then don't take them as they might be intended to be taken. Now, this could be a patient decision because maybe you've had a side effect that you don't like, so you've made that decision, or it could be that actually the way and the number of medicines that you've got to take is too confusing, or it doesn't work with your lifestyle and it needs adjusting and changing. So it's important to think about that with the patients and to agree that with the clinician, so that as patients you feel that you can have these discussions about what's going to work and help support you, because we do know that there are harmful consequences of not taking your medicines, particularly acute exacerbations of asthma, for example, or people not getting adequate protection from secondary prevention of diseases such as after a heart attack. You may take medicines to prevent another one, and if you don't take those medicines, you could be at increased risk of another event. So it's just important to have that conversation and for the clinicians to really make sure that the patient is part of that decision making. And we can see here on the diagram, one patient's way of trying to manage the multiple medicines is to just put it into a device. And if you look very carefully, it's just being used as a storage. So if another carer was to come in and that patient fell ill, there could be some really harmful unintended consequences here. So next slide, please. So many people ask, well, can't we just have a poly pill? But a poly pill could be the answer, so long as we make sure that whatever is in that poly pill is right for that individual patient. We can already print some tablets, but what we need to make sure is that combination is right for that individual, and therefore we need to review the medicines that an individual is on. Next slide, please. And we know that from some of the European work that we did, that 8.6 million admissions every year happen because of harmful events caused by medication-related harm. And we know that 50% of these are preventable, with 70% of these occurring in patients over the age of 65 or more, taking 5 or more medicines. So again, you can see it's not a huge number of medicines that people need to take before it causes harm. So next slide, please. So Helen asked me to particularly focus on some of the tools that we have made available in Scotland for patients to access, and that is open and available for anyone across the globe to access. And indeed, we've used them and shared them with our European partners as we've been doing the work on the European projects. But the premise really is that when medicines are started, reviewed, or a person moves across a care transition, a person has a review, but the first question has to be, what matters to you? What's important to you? Because we also need to think about lifestyle. So if you cast your mind back to those 2 images I showed you, the lady on the exercise device and the gentleman sitting on the sofa, the medicines that the lady will be taking, she clearly needs to want to make sure that she can continue to exercise, that she can still be active. So we need to think about the individual, what's important to them, thinking about, is this the right medicine for them? And making sure that we remove any unnecessary medicines or medicines with a poor evidence base. if you are started on a medicine, then it's important to tell the clinician whether this medicine is working for you or not. They can use tests, but also you may feel the benefits of a medication or not. For example, if you're given a medicine for your asthma and your breathing, you need to know that that's working for you. And if it isn't, you need to be able to report that back to a clinician. Again, patients often pick up side effects. If somebody's prescribed aspirin, do they start to develop stomach symptoms that might tell them that I'm starting to experience side effects? And so asking patients if they're experiencing any harmful side effects of the medication. And cost effectiveness is really important if people pay for their medications. And so you need to balance that with what the patient can afford and take. And importantly, the very last step is that it's important that we start with the individual, the patient, and then that we come back to the individual patient as well. So we agree and share a plan that the person is happy to go along with, or their carers are happy to put into action after the discussion from the medicines review. And so we've developed an app which you can download from the link that you've got there, or just Google on the App Store. It's a Managed Medicines Polypharmacy app. And one of the things that comes up here is, again, as you go into it, you go into the patient and carer section, and it says questions for my review. So you can prepare the questions that you want to ask your clinician before you go in. Next slide, please. And this is how it can look for you. So there's a section for healthcare professionals so they can support you best. And there's a section specifically dedicated for patients and carers. So next slide, please. And these are the 7 steps. Again, they're set out so that if you want, you can delve into these further and think about what you might want to get for a review. So next slide, please. And again, there's a facility on here for you to be able to record all the medicines that you're taking. So as you might move across a care transition, you can log those, or you can look up information about the medicines that you're taking and find common side effects that you might want to be aware of. Next slide, please. And there's also information on here. If you click again, please, on just information about, which is represented in a pictorial way that helps you as an individual make decisions about whether a medicine is going to benefit you or not. So next slide, please. Okay, so this is how it will look. So if you click onto it, there'll be a grey face that shows that you're not going to benefit from the medicine, and a green face that shows a patient that benefits from the medication. And so if you go to the next slide, you'll get a pictorial representation, therefore, of whether the medicine is going to benefit you or not. So the other tool that we've developed is what we call the sick day guidance. And in particularly during COVID, this was quite important as people fell ill. So clicking on the tab of what to do when I'm ill brings up the shot that you see that's on the far right-hand side. So next slide, please. And you can see here the common medicines that when an individual becomes sick because of dehydration, vomiting, or diarrhea, these medicines, if they continue to be taken, can make you more vulnerable to damage to your kidneys. And these medicines sometimes need to be temporarily stopped. And so this first shot just highlights the common medicines that there are, but it also provides a section at the bottom for an individual clinician to work with the patient and find out the medicines that they're taking. So next slide, please. And if you just click, click, and click again, please. And what you can see here is how it's set out so you can access each of them and you can see each one and write your individual medicines. And click again, please. And you can see here that you could write your own medicines that you're taking, and that if you are concerned, you could then email that to your healthcare provider and share that with them, and that you know what you need to do. So this is the sick day guidance that you can access. So next slide, please. And what I showed to you before was a pictorial representation, and this is just for another medicine. So this is quite often people during various times in their lives have difficulty sleeping. And one temptation is to think that actually I would quite like a tablet or something to help me sleep. And what this pictorially shows really is the number of people that are not going to get any benefit from it. The green smiley face shows the one person that will get benefit, and the red shows the people that are going to get harm. And this is actually for a sleeping tablet. So you can see that actually there are more harms than good from taking a sleeping tablet. And these are the kind of tools that are used with the other medicines that are in the app that help you as patients make the decisions about the benefits and the disadvantages of taking certain medicines. So this is what we are really focused on, is the shared decision making to prevent harm as well as addressing harm. So next slide, please. And so I'm going to just briefly tell you about the current work that we're doing. So we've got a 3-year EU funded project, which is coming. We've got about 7 months left. And we're doing it across many sites, hospital, outpatient clinics, and in primary care, looking at providing patients with person-centered reviews, as I've described. So next slide, please. And just to really sort of highlight that quite commonly people have 6 to 7 comorbidities. They're taking between 9 and 11 medicines. And on average, we stop 2 medicines. And the majority of interventions that are made using this approach have a significant improvement in the patient outcomes using a validated scale called the Eden scale. So it's either improvement in the standard of care for that individual, or it's been a prevention of organ failure or an adverse reaction or something similar. So you can see that a person-centered approach with shared decision-making can have a real benefit for an individual patient. And it also reduces the inappropriate use of medicine, which we've measured using a person-centered medication appropriateness score. Next slide, please. We also collected data from patients. And what we found from patients is that they reported through PROMs that they felt a 95% improvement. But if you look at the chart as well, we also monitored the safety indicators which assess medication-related harm. And we can see over the course of time in which this guide has been certainly in place in Scotland, that there's been a gradual decline in the percentage of people that experience harm. Next slide, please. And we have a series of about 69 indicators and 17 of these that we can monitor nationally that help us make sure that we are reducing harm to individual patients. And I'll just give you a minute to just read some of the comments that have come back from both clinicians and patients. And really just, what strikes me is the individual saying it means so much to me to be involved in the decisions about my brother's care. And for me, that's what it's about. It's about making sure the individuals can be part of the decision making. So next slide, please. So I'll pause there, and I know we're going to take questions at the end. So I'll look forward to receiving those off you at the end. And thank you very much, everybody, for listening.
Thank you, Alpana, for that outstanding presentation and all those wonderful patient tools and methods to improve your medication safety. I've put the links to both the WHO tool and to the Scottish Government website that gives you access to all those tools in the chat in case you want to access them now, so you'll have them in your computer. Our next speaker is really a virtual legend in the world of medication safety. I would say that Mike Cohen has left his imprint on almost all the major advances in medication safety in the past few decades. He's President Emeritus of the Nonprofit Institute for Safe Medication Practices. He's chair of the International Medication Safety Network. He's received numerous awards, including the Eisenberg Patient Safety Award from the National Quality Forum and the Joint Commission, and the Whitney Award from the American Society of Health System Pharmacists. And he is a MacArthur Fellow recognized by the John D. and Catherine T. MacArthur Foundation. And he is going to talk to us today about taking your medication safely. Mike?
Thank you very much, Ellen. I'm honored to be with your group. It's good to meet everyone. May I have the first slide, please? My area of expertise has to do with preventing medication errors, taking medication safely. And I am President Emeritus, as you heard, of the Institute for Safe Medication Practices, but also chairperson for the International Medication Safety Network. We have about 25 countries that are involved with that. And we have several regulators that are members, and we meet regularly on different projects. Right now, we're having a project on oxytocin, which is used, of course, in obstetrics and sometimes used unsafely. So we're coming up with prevention recommendations. But at any rate, it's great to be with you. And I'd like to talk about taking medication safely. So may I have the next slide, please? And just so you're aware, we actually operate a reporting program in the United States, and there are similar programs in other countries. In fact, the Institute itself has a sister organization in Canada, in Spain, and also in Brazil, ISMP Brazil. We receive reports of medication errors from providers, from practitioners, nurses, doctors, pharmacists, but also from consumers after they have been involved in a medication error and they want to let us know about what went wrong. And we try to publicize that wherever there is a good chance of learning from the incident. We have newsletters that reach 5 different areas, including consumers. And we have a consumer website, which I will show you in a little while. But we serve as an early warning system. So if something very serious happens with a medication error, we have a national alert system to get that information to the provider organizations, including pharmacies throughout the country, as well as hospitals and ambulatory surgical sites as well. We're aided with that by the National Coordinating Council on Medication Error Reporting and Prevention, which is a group that's housed at the United States Pharmacopoeia, and they've been very helpful. So whenever it's about learning from an error, stimulating change, we've got a lot of product changes, labeling, packaging, drug naming, for example, are often responsible for confusion. And we have a memorandum of understanding with our US Food and Drug Administration. And we pass this information on to them, work with them on a regular basis, and they can take steps to work with the company and get product changes as necessary. So literally hundreds, if not thousands of changes have come from that. Also standards and guidelines in medication safety by our oversight agencies like the Joint Commission, USP, the United States Pharmacopoeia, and FDA. So on the left, you see one of our newsletters. That's the institutional newsletter. That comes out every 2 weeks and goes to all hospitals in the country. We have others for nurses, for community pharmacists, for patients, and for long-term care facilities as well. Next slide, please. So medication errors obviously happen. And we have actually defined through that NCC MERP organization that I mentioned what a medication error is: any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. And that includes examples like prescribing errors made by the prescriber, doctor, nurse, pharmacist, whoever might be doing the prescribing, dispensing, usually pharmacists, administration errors, people giving the medication to someone else, or patients taking the medication themselves, improper patient monitoring, post-administration. Some of the drugs that we use, people aren't familiar with the monitoring processes, and unfortunately, we don't identify potential harm that comes from the medication. And a big area for us has been with regulated products and correcting problems with labeling, packaging, and drug nomenclature, the names of drugs. I'll show you some examples of that in a minute. Next slide, please. So medication errors can occur pretty much anywhere, and I want to go into each of these separately. Your doctor's office, your local pharmacy, obviously in the home, the way you store drugs, for example, can contribute to that. Obviously in hospitals or healthcare facilities, and then other areas where medications are given to, like schools, camps, long-term care facilities, and so on. Next slide, please. So let's go into some things that you need to be aware of at the doctor's office. Next slide. So one of the things that we highly recommend is, obviously, and you hear that from anybody in safety, and you know it well, and that is being familiar with the medication you're taking, what it's for. And that can really be very helpful in making sure that you get the right medication when you visit your pharmacy and they dispense the medication. There needs to be a conversation there, and we'll talk about that in a second as well. So you really should get from your physician a list of the medications when you leave the office, so you have the current medications that they're prescribing. And most of us do have computer systems in the United States, so that's relatively easy. I realize that may not be a case in different regions of the world, so that might have to be done manually. But by and large, a lot of the doctor practices do have computers, and they're able to print out the list of prescriptions so that you know what you're getting, and you'll get a paper copy, in other words, and bring that with you to the pharmacy, especially when a new prescription has been written. You want to confirm that the medication on the list is what is being dispensed for you. You'd like to know the reason for the medication too, because some of the drug names, and I'll show you that in a minute, are so similar that you could easily pick the wrong item off of a computer screen or read someone's written prescription, handwriting, for example, incorrectly. And that can even happen with good handwriting, not necessarily bad handwriting. If you know what the medication is for, and the pharmacist tells you something other than what you expect, then you can question that. And that's why it's so important to know about it. So know the reason for each medication. And I even recommend with new prescriptions asking for a duplicate invalidated prescription, so you have that information. If not, at least a list of medications in a printout. Next slide, please. At the pharmacy, next slide, please. Our reports include one of the most common types of errors that we get. And I realize, you know, in the United States, we use plastic prescription vials or bottles with loose tablets that are placed in that vial by the pharmacist. By and large, throughout the world, they're generally using patient packs, which I think is an advantage because that has the manufacturer package. It has the name of the drug on it, the strength, and even barcodes that the pharmacist can utilize. So that's actually an advantage outside the United States. But in either case, in many cases, they don't just hand you that product, they place it in a bag. And unfortunately, throughout the dispensing process, there are many steps where a mix-up can occur and someone other than you has their medication placed in your bag and your name is on the outside. So that is the most common error that we get from community pharmacies as opposed to hospitals. So another one is correct patient, but the wrong medication in the container, wrong dosage form or wrong formulation, wrong quantity, different capsules and tablets mixed together. I'm sure you've heard of some of these or may have even experienced themselves. And some of the liquid antibiotics have to be reconstituted with water or there may be two components of a liquid that have to be mixed together other than just water and the powder. And sometimes that doesn't always get done. So you need to present that back to the pharmacy because the proper measurements have to be made. It can't be done at home or it may become too diluted. And then finally, one of the issues we have in the United States is pharmacies often have automatic refills And even though the medication may have been discontinued by the doctor, it continues to be refilled. And then the patient gets confused and starts taking that medicine at home. I don't know how prevalent that problem is outside the US. Next slide, please. We actually did a study, and I have that article here, looking at the different types of errors. And without a doubt, this wrong drug in the bag was the most common, happening over 1 out of every 1,000 times a drug was dispensed. It had someone else's medication in the bag. So it is essential that you don't just go home and take whatever medication has been dispensed to you. You have to look at the label and look at the name on the container. And when you do that, you can drastically reduce the possibility of taking the wrong medication. And that's the data that we have in this particular study, showing it drops by more than half the risk. Thank you. Next slide, please. And always open the bag, as I just said. It's a great way to prevent errors. Also, speak to the pharmacist about the medications that you're on, and make sure that he tells you the proper reason for the medication and goes over the directions, answers any questions that you have. I don't think we do that often enough. And all too often in busy pharmacies, the pharmacist doesn't step forward and the patient has to demand that, but it should be done. That is really important to get the right medication for you or for your family members. And obviously, if it's not what you expected, you want to call that out to the pharmacist immediately. Don't be afraid to do that. Next slide. So these are some of the drug name mix-ups. This patient was supposed to get a product called hydroxyzine, which is a medication that's an antihistamine. And you can see how similar the names are. Hydralazine is for blood pressure. This is one of the most common name mix-ups that we get. Well, one of the things that we've recommended is using elevated case for those unique letter characters to help the parts of the name that are different stand out. But again, if you were talking to a pharmacist and said, the pharmacist told you, here's your blood pressure medication, or if the physician put the purpose of the medication on your prescription and you knew what it was for, you'd be able to stop that type of error before you ever even took that medication out of the pharmacy. So this is a typical error that we get from consumers and pharmacists. Next slide. We do have a lot of drug name mix-ups, and on our website in the United States, we have both the established name or the official name and brand names, most of which are used throughout the world, by the way. We have very similar brand names for most drugs. And we have this on our website. On each of our slides is our website, ismp.org, and also our consumer website, which I'll show you again in a second, has a list of these medications that look alike. So when you get home, if you look at the label on your container and you go to this location and look up the drug name, you would be able to see what else it might look like. So that would help you to prevent the medication error. Next slide, please. Also, leaflets come with the medication drug information, so that helps. We do provide for particularly potentially harmful drugs. We call them high alert drugs because they're often the ones that are used that can cause serious harm or fatal events even. We have on the consumer website special information sheets and checklists to make sure that you are taking the drug appropriately. So you will find that on our website as well, which I'll give you in a minute. Next slide, please. And just to go over some reasons to expect a pharmacy error, if the appearance is different than expected and the pharmacist hasn't warned you that they've switched the manufacturer, that might mean there's been an error in the dispensing. If the smell or taste is different from what you expect, if the number of pills in a prescription container is different from what you expected, the amount of liquid in a syringe or the bottle or the number of pills you need to take per dose is different. And by the way, if you need to take more than 2 or 3, you should talk to the pharmacist. The chances are either an error happened or a dosage form can be switched so that you only need to take 1 tablet or 1 capsule. That's often the case. And then also suspect an error if the directions on the prescription bottle different from what you learned at the doctor's office. Next slide. And additional reasons to suspect an error. Obviously, if the patient's name on the label isn't as it should appear, and that can be junior versus senior. Also, the pharmacist should always be asking your name and at least one other identifier like your birthday or your address. If the doctor's name on the label isn't correct, maybe something's wrong. If the name on the medication bottle isn't what you expected, if the reason for taking the medication is different from what you're being treated for, you need to ask about that. And then finally, after reviewing a prescription, you just don't feel right and experience new side effects and begin to notice physical changes after just a few doses. Perhaps there's an error. You need to check that out and call the pharmacy. Next slide. Just have a couple more slides, I think. In the home, next slide. Drug storage is critically important. You want to keep certain items up and away and far out of sight of children and pets. Be careful how you dispose of them. They don't go in the trash. Our dogs, our pets, our cats get into that very easily. Sometimes our children do as well. And some drugs are particularly dangerous. The fentanyl opioid patch, for example, we've had children put them in their mouth after finding them on the floor or stuck to a countertop, for example, when the patient was changing it. And that contains a significant amount of fentanyl even after it's been used. And that has caused some fatalities. So really important how you store and dispose of medications. Next slide. And obviously medications can look like candy. So our poison control centers remind us of that. Obviously you want to keep these pills and capsules, et cetera, out of the reach of children. Next slide. Yeah, all the way over there on the left, nail glue has wound up in patients' eyes. Wart remover has been applied instead of medicine for chapped lips, topicals for chapped lips. So again, be careful when selecting these drugs, when storing them, when picking them up. Always make sure there is a well-lit room for you to be able to read the label. Use a magnifying glass or make sure you wear your corrective lenses, your glasses, whatever. Don't take any chances. There are these lookalike products out there that can cause serious harm and are very difficult to reverse damage. Next slide. This is our consumer website, and the consumer website URL is at the top there, consumermedsafety.org. We have literally hundreds and hundreds of articles. You can type in any word that you'd like to search. There is a reporting program that's available to consumers here to communicate information to us. We have special areas like insulin safety, purchasing a medication without a prescription over the counter. There's a lot to learn there as well that we don't have time to go over today, obviously. But please do go to the consumer website. Everything on it, obviously, is without charge. And next slide, please. It's meant to educate. These are some of the newsletters that we have. The Safe Medicine newsletter is available on the consumer website. Every article is there for free. If you'd like to purchase a subscription to the Safe Medicine PDF version, there is a very slight charge. I think it's just over $10 a year, and that comes every other month. It's up to you because the articles are available for free on the website. Next slide. And I think that's it. So I'll stop there, Helen. Thank you very much, everyone, for your attention.
Thank you, Michael, for that very informative presentation. I've seen lots of questions going up in the chat. Can we have the next slide, please, Harris? So our next presentation is from another eminent researcher, Professor Phil Routledge, who's Emeritus Professor of Clinical Pharmacology at Cardiff University in Wales, and he is President Emeritus of the British Pharmacological Society. Professor Routledge was the main author on the 2019 WHO Technical Report, High Risk Situations in Medication Safety, and he was appointed to the Order of the British Empire in 2008 and as a Commander of the British Empire in 2018, among the highest honors in the British Commonwealth, both for services to medicine. So Professor Routledge unfortunately could not be with us today, so he comes to us via recording. And if you have questions for him, put them also in the chat and we can forward them to him if one of our other speakers can't answer them. Harris, could you please play the recording?
Hello, everyone. My name is Philip Routledge. Those are my honorary affiliations, but what I'll be saying today is my own views and not necessarily the views of those organizations. I come from a small country on the west side of the United Kingdom called Wales. Wales has a population of only 3 million people. So a small country, but with all the challenges of countries with healthcare challenges. I was delighted to be asked in 2017 to be part of the Medication Without Harm team by Sir Liam Donaldson of the World Health Organization. My interest as a physician and clinical pharmacologist for many years had been in how to prescribe safely and effectively. Prescribing, administration, storage, and dispensing of medicines is actually a very complicated issue, as you can see from the list of things that have to be got right at each stage. It involves a group of health professionals and patient in what I call a prescribing partnership, where the key is regular and clear communication between all members of that partnership. In 2012, 100 years after the Titanic sank on its first maiden voyage, I wrote an article about the reasons that such errors led to disaster, and compared them with the reasons why sometimes medicines can cause harm which is avoidable. In the case of the Titanic, the communication failures were around the fact that the ship closest to the Titanic, when it hit the iceberg, the Californian, couldn't hear the SOS messages because its Marconi wireless, which was powered by the ship's engines that had been turned off, was unable to detect them. The critical conditions in that scenario were that it was particularly cold, and as a result, there were icebergs at lower latitudes than there would be normally. Complacency, perhaps, had been fueled by the fact that this ship was thought to be unsinkable because of its size. And corner cutting was an issue in relation to the fact that for the first time, unlike its predecessors, the transverse bulkheads, which kept the water in compartments if it leaked into the ship, were only 10 feet above the sea level rather than the 30 feet like its predecessors. The word callowness is an old Saxon word, I believe, which means unpreparedness, lack of training, youth, or inexperience. And certainly there was inexperience on the part of some of the sailors who had a very short, cursory introduction to how to lower the lifeboats when the ship was docked in Southampton. And of course, this may have had implications to the way the lifeboats were used during the sinking of the ship. As you can see, there are several reasons why that particular tragedy occurred. And this fits what's called by reason the law of cumulative effects, where there are meant to be defenses in systems that prevent risks becoming harms. And in reason's Swiss cheese model, the holes in those defenses sometimes line up, allowing the risk to go through each defense and become a harm. The World Health Organization therefore commissioned 3 technical reports, of which one was medication safety in high-risk situations, which many of us, including myself, Dr. Cohen and Alpana Maya, were involved. High-risk situations include the 3 Ps of prescription factors, people, and places. Here I'll talk mostly about prescription factors, and particularly so-called high-risk or high-alert medications. Alpana will cover the issues around polypharmacy. I've already alluded to the central role of that prescribing partnership between healthcare professionals and patients. That is the key to safety in high-risk situations. And finally, there are issues around the places where prescribing and administration and dispensing of medicines occurs, whether it's in the hospital or in the community, or in some much more high-risk situations, such as in operating theatres or in neonatal intensive care units, for example. Let me talk about high-risk, high-alert medications. And first, just some basic pharmacology. If you take a piece of graph paper and plot the dose of any medication against its effect as a percentage of its maximum effect, the shape of the relationship on a logarithmic scale is an S shape, a sigma curve. Between that dose and that dose on the horizontal line, we have what we call the therapeutic window. That's the safety margin between the dose that causes benefits and the dose that in most patients might cause side effects. However, with high-risk drugs, high-risk medications, or high-alert medications, as they're also called, the dose-response curve is much steeper. And therefore, the difference between the beneficial dose and the side dose likely to cause side effects is much smaller, and the therapeutic window much narrower. And that means that those medicines are more difficult to use. You might ask, well, why do we use them? And the answer is because many of them, as well as being high risk, are potentially high benefit, and in many cases, life-saving in certain circumstances. And therefore, the optimal situation is to enhance the benefits and optimize them whilst minimizing the risks. The technical report lists some of the high risk or high alert medications. In this useful classification from the state of New South Wales, a list of high risk medications is shown to spell A pinch, O, A for anti-infectives such as certain antibiotics, P for potassium and other electrolytes which are often injected, and injecting medications, whether they be electrolytes or other medicines, is potentially a high-risk situation. Insulins, followed by narcotics and other sedatives. Drugs used in cancer, chemotherapeutic agents, and then, of course, the anticoagulants such as heparin and the oral anticoagulants such as warfarin and the newer anticoagulants. And then a list of others which may be high risk in certain circumstances and therefore should be identified proactively in situations where they're to be used. The reasons for high risk medications causing errors are listed here in a study from Alan Zani and colleagues. And you can see that the dosage problems, either the wrong dose is the commonest cause, However, prescription errors also occur in other parts of the prescription, such as a missing or an incorrect weight, a lack of adherence to prescribing policies. And one important issue is that sometimes the omission of a medication may potentially harm the patient more than other reasons. And so the lack of obtaining an effective medicine is classed as an error. No prescription date or the wrong prescription date can also be an issue, as can drug interactions. How do we address these? Well, the Institute for Safe Medication Practices, Grissinger, has published a list of strategies that can be used to address these issues. I won't read them in detail, but what is important to say is that each of these is not mutually exclusive. The best way to address these issues is to use a bundle of these strategies to ensure that error does not occur. I'd just like briefly to highlight two of them. The one of maximizing access to information, and the other one about standardization of processes. In relation to maximizing access to information, the British Pharmacological Society, together with the United Kingdom Medical Schools Councils, approved an assessment, the UK Prescribing Safety Assessment. It's an assessment for trainees in medicine, which in the UK doctors have to have before they practice and prescribe. The learning that they need for this assessment is supported by the British Pharmacological Society with an e-learning package called Prescribe, and there are interactive e-learning resources as well. At present, it's being trialled for other health professional groups because increasingly other health professional groups are prescribers of medicines. This is the structure of the so-called PSA, and the actual process of prescribing on a sheet or in or electronically is only part of the important skills that are needed to use medication safely and effectively. Reviewing the prescription, planning the management, and so are particularly important. I'd like to highlight the importance of drug monitoring because many medicines will be used for considerable periods of time, requiring regular monitoring. And of course, adverse drug reactions is a technical term for side effects, and it's important that prescribers are aware of those potential side effects. In relation to standardization, in 2004, in Wales, the Chief Pharmacist Committee developed a single national inpatient medication administration prescription chart, which means that prescribers, wherever they are in hospitals in Wales, use only one prescription form. Prior to that period, different hospitals had different charts, and unfamiliarity with charts is one of the reasons why errors may occur. In order that training was facilitated, all Wales prescription writing standards were agreed nationally, and an e-learning training package provided for those training to prescribe. In Australia, where a single national chart for inpatients was developed in 2005, it was associated with a reduction of prescribing errors of almost 1/3. So standardization is an important strategy. WHO have developed some resources to remind people of the importance of knowing, checking, and asking. Knowing relates to the antidote to what I called callousness, lack of training. Checking is the antidote to corner cutting and complacency. And asking is, again, the importance of education and addressing lack of training. Doctors are encouraged to know their medications, to check they have the right patient medicine, route, dose, and time of administration, and to ensure that that prescribing partnership is an active one where patients understand what has the information that has been given and have an opportunity to ask for advice. For patients, the approach is called SAFER because it's starting a medication, adding a medication, following, ending, and reviewing the medication, the first letters of which spell SAFER. And knowing, checking, and asking is a component of each of those 5 moments. Know your medication, check the dose and time, and ask your healthcare professional. Just finishing now this section, I wanted to mention the issue around the reason why there were difficulties in communication. The Californian, the RMS Californian was only 19 miles away, and yet even when white rockets, which spelled out disaster, were let off in the night from the Titanic, the Californian did not move. Whereas the Carpathia, the RMS Carpathia, which was 58 miles away, heard of the problem. Arthur Ostrom, the commander of the ship, the Carpathia, sailed full sail ahead through the icebergs to the Titanic and rescued as many people as could be rescued from the seas. He showed great courage and commitment, and in the Titanic incident, that courage and commitment was used to try to mitigate the communication failures, the critical conditions, the complacency, the corner cutting and callousness that had resulted in such a disaster. Clearly, prescribing can cause issues, and it is important that we who are involved in the prescribing partnership show courage to ask questions when uncertain about what needs to be done or what the side effects are of the medicine, and a commitment to concord with to follow the advice when accepted, and question it when it's unclear, is an antidote to some of the issues that can occur as a result of those circumstances on the right of the scale. And by doing that, prescribing can ensure that the benefits are optimized and the risk minimized. Diolch yn fawr, it means thank you very much in Wales, and I'm very grateful both to the World Patients Alliance for the invitation to talk at the Patient Safety Day, and also to all of you for listening at the other end. Thank you very much indeed. Hello.
Many thanks to Professor Routledge, and I particularly appreciate his final point, the importance of speaking up, which applies to both patients and providers. Sometimes, even for patients, it takes courage to speak up. So our final speaker is Helen Nagaje, who's coming to us from the world of pharmacovigilance, which is adverse event reporting and drug safety. She's a pharmacist and clinical epidemiologist and the director of product safety at the National Drug Authority in Uganda. She's president of the African Society of Pharmacovigilance and holds a master's in business administration and a doctorate in public health. And she is known for having introduced a decentralized system of pharmacovigilance in Uganda. She is going to talk to us about some of her very innovative research on community education in Uganda, and some of the other research perhaps that she has done also in Uganda. I'm really looking forward to hearing this. I think it has a lot to say about how we can all raise our health literacy. So thank you, Helen, and please take it away.
Thank you very much, Helen, and thank you, the organizers, for inviting me to speak at this event. And I'm very grateful because it's really a passion to share that the community can have good input into our work, even as regulators. So I'm the director for product safety, and I also am a member of the ISOP patient engagement special interest group, as well as the Africa chapter president for ISOP. Next slide, please. Yeah, just coming from a country that has, in the heart of Africa, that has over 40 million people, and there's a lot of investment on behalf of the patient by out-of-pocket expenditure of close to 40%. So anything that can do that can be done to make medicine safer, I think will go a long way in helping the patient. Next slide, please. Yeah, so as previous speakers have mentioned this afternoon, I don't know whether it's also morning or evening in some parts of the world, I would like to mention that unmatched expectation between the healthcare provider and the patient is very important in medication safety. And this is from a research that we have done previously, going to the community and asking specifically the healthcare providers and also the patients in community setting. And it was very, very interesting to find that the patients preferred to listen in from radios, well, also to listen to their healthcare providers, while the healthcare providers thought that what was more important for as a source of information for reaching the community would be the community meetings, which we had scheduled with the help of the community leaders, and also other sources like the health facility were quite important. So there's always that mismatch of what the healthcare provider thinks and the patient. Can I have the next slide, please? So it's then therefore important to look at evidence to inform decisions, and we have decided that we look at what the patients are reporting, or what is even the healthcare providers are reporting, and from the spontaneous reports. And from these, we've had some patients really express we've had the patient's voice about the medicines they're taking. And one of the papers that we've recently published, I would like to make a quote. It says that this drug, which was dolutegravir, took something from me. The patient felt that it's taken away their physical strength, it's broken them down, and it has made them weak, which was not the case with the earlier drug they had been switched from. So it's very important to work with the healthcare professional in this journey of achieving medication safety, even from the community aspect or consumer aspect. Next slide, please. In terms of our approach, we've also studied not only the kind of reports that we are receiving, but also the interventions, because we realized that we were talking mainly to the healthcare professionals. We had, because of resource limitations, we were going mainly to the healthcare providers to be able to get reports. But we then soon after realized that talking to the community in their setting would be very useful. And this, we still continue to get patient voices. For instance, people talking about their child, my child had convulsions and was treated with quinine and became crippled. And that's, but I knew that that was how the medicine works. So when the patients get to open up, we're able to educate them and also help to correct the misinformation. And also there was the issue of use of family planning, that some people thought that family planning makes some people gain weight, huge in size or small in size. But this again is helpful to the patient to discuss with the healthcare provider in finding a solution. Next slide, please. So when it comes to the voice of the patient, we really realize that, yes, the patient is very, very important. And we've had a number of community organizations such as CHAIN, Community Health Action Initiative, a network of organizations that we've worked with in promoting this, because this is a model of that can be sustainable, because all the resources that are needed to get to the community are not in one place. There are advantages and people who have been working with the community that we decided to partner with. And it was very heartwarming going to also the villages, the village health teams, and using the community leaders, gathering the community and us talking to them about medication safety and report, and how they can report to the National Pharmacovigilance Center and be helped also at the health care facilities, and also the healthcare providers talking to them in the facilities has helped them to see and be able to open up channels that can help the patient be more responsive. And in terms of, because the patients had told us, yes, the radio is what makes us, what helps us, that's our cheapest and most available means of communication. We've done a number of radio talk shows, and when opportunity arises, we also have gatherings also to talk about, as a form of an accountability, to talk about pharmacovigilance at the national level. And this talk show was basically talking about pharmacovigilance, and also the main highlight of this was the patients reported a lot in this year. The last year, when we engaged the patients more closely, we had more than 10 times the reports that we had been receiving from the healthcare providers. Next slide, please. Yeah, so apart from that, we also have other studies ongoing, and this is just something that is not yet published. It is preliminary. So it's a study to determine whether the toll-free line that we have as an addition to reporting, an additional method to reporting, whether it's useful, it's as useful for the patients as for the clinicians. I will discuss about the patients. The data for the clinicians is not yet out, but out of the close to 500 patients we interviewed, 75% of them had reported at least one adverse event. And we go to the clinicians, and the clinicians were given some training, as well as the toll-free line to share. And also the patients were also given minimal education, yes, and a free line to share. And also after 1 month, we gave them we gave them a reminder via an SMS message. And we had these results after 6 months from the patient side. Around 38 of them said they preferred, when they called it when they received an adverse event, they were able to call the NDA toll-free line. And also just only 2 of them said they took no action at all. Next slide, please. So it has helped us also to look at the level of patient satisfaction, that at least more than half of them felt they were satisfied. And some of the reasons they were talking, they were giving us, or some of their voice was saying that when I called in, the receiver gave me proper counseling that boosted my morale. So they should keep it up, because it makes me feel loved and cared for. And that's what is important. It's a relationship thing. And that's what is important also in assuring that the medicines can be made safe when that relationship is going on. And then also the team was knowledgeable. They felt that their issues were addressed, and that they could recommend it to others. The other things that we have found out from the toll-free line, of course, they were not happy with, we were only using English, and yet we have a number of languages that are available in the country, and that is something that's good feedback for us to improve on the system. And also, of course, this in spite of the limited resources, I know that the patients are asking for more. Can we be available over the weekend? Can it be a 24-hour availability? And they asked us to follow up and keep following up. And then they also said that we should work with the clinics to provide drugs to manage the adverse drug events, because many times the clinics have budgeted only for the medicine that is for, say, like for HIV. But if the medicine has other effects, say like for mental health, then sometimes the facility or the clinic is not able to provide that. And in the government facility, they feel they don't want to go back to the facility, since we always keep sending them as part of the toll-free line. We send them back to the facility where they got the medicine to actually get managed and get help. So they felt that also that doesn't work for them, because they when we refer them back to the doctors where they got the medication, they have to stand again in the long queues, and it takes much more of their time. Next slide, please. Yeah, so the important lesson we have learned from the community outreach is keeping the communication lines open, and that the evidence is important for us from the research to inform patient involvement, and also that the more patient-friendly reporting channels have helped to improve reporting. Say we have an app for reporting, a mobile phone app for the MedSafety app for those who have smartphones. And then also we have a WhatsApp number, and also a USSD code for those who do not have WhatsApp, smartphones. They are able to send a message, and we follow up, especially helpful during the COVID, studying the COVID vaccine effects. And due to these reporting channels, patients now double the reports from the top reporting health workers. Next slide, please. Yeah, this is just a trend from the kind of reporter, just to say the same thing differently, that in the last 2 years, the number of patient reports have been much more than all the others combined that we have received since we started reporting almost more than 10 years ago. Next slide, please. So when we asked the people what method was the preferred reporting method, many of them referred to the toll-free line, and that is very important for a limited resource setting, because sometimes also the resources, when someone has to divide between buying a food and a medicine, it is an added advantage that they don't have to spend extra on explaining if they got an issue with their medicine. Thank you. Next slide. So in summary, we believe that patients have unique insights into the medication safety as they are directly affected by the adverse events, and that these patients are willing and able to participate in keeping medicines safe if they are engaged, because that was our initial fear, whether patients would actually be able to give us useful information. But in Uganda, we have engaged them through the village health teams, and we have also encouraged them with cost-effective reporting options like the USSD code and also the toll-free lines that do not require extra expenditure on their side. Next slide, please. Yeah, I want to thank my collaborators and the National Drug Authority, Jane, IDI, and all of them that I haven't mentioned, put on the slide. I'd like to thank them. And I thank you once again for inviting me to speak here. Thank you.
Thank you so much, Helen. That was a wonderful presentation and really very thought-provoking. We are not going to have time, I don't believe, for any speaker discussion. We have the questions in the chat. We may be able to forward those to the speakers. I'm not sure exactly Hussein or Harris could help us with getting the answers back to people. But this, I think, has just been a wonderful series of presentations with different aspects of how patients can be involved, what patients need to know, how to help both patients and providers improve medication safety. So thank you to everybody who has come. Thank you so much to our speakers, who could not have been more informative and more interesting. I appreciate you all attending our webinar. It will be recorded. It will be online at the World Patient Association website, so look for it there. Thank you and goodbye.